Thank you. Good afternoon, everyone. My name is Suresh Ramalingam. I'm a thoracic oncologist and professor at Winship Cancer Institute of Emory University in Atlanta. Welcome to this webinar. We hope that you will find this discussion to be both informative and educational. At this time, I would like to introduce my esteemed colleagues joining me for this discussion today. First, Dr. Leora Horn is Ingram Associate Professor of Cancer Research, Associate Professor of Medicine, and Assistant Director for Educator Development Program and the Clinical Director of the Thoracic Oncology Program at Vanderbilt Ingram Cancer Center in Nashville, Tennessee. Then Dr. Jacob Sands will be joining us. He's a thoracic medical oncologist at Dana-Farber Cancer Institute and an instructor of medicine at the Harvard Medical School. And last but not the least, Dr. Charu Aggarwal, who is a Leslie Heisler Assistant Professor for Lung Cancer Excellence and Medical Oncologist at the University of Pennsylvania. Welcome, everyone, for this discussion. Let's first start by having some disclosure information to you. All our faculty disclosures are in the slides. This webinar has been provided by BioSN. BioSN is an independent medical education company committed to supporting healthcare providers in their efforts to translate innovative science into clinical practice. Let's get started. And I would like to have the first question to Dr. Leora Horn. Dr. Horn, can you talk to us about how COVID has impacted your practice and what is the current situation in your institution now?
Yeah, thank you, Dr. Ramalingam. So, you know, Nashville's a little bit different, I think, from some parts of the country that have been hit hard, in that we prepared for a influx of patients coming into our ER and our hospital with COVID-19, but it never really happened. And so our clinic sort of paused for a couple of weeks. We were seeing less new patients. We were deferring a lot of patients who were on routine follow-up, and we were switching over to telehealth. I would say in the last couple of weeks, it's been a little bit more of business as usual, where patients are getting their scans again. Patients are coming into the cancer center for follow-up, although we are still doing quite a bit of telehealth for well visits. And for a while, we were seeing less early stage disease because surgeries and bronchoscopies that weren't essential were put on hold. And now that our surgeons are operating again and the biopsies are being done again, we're anticipating seeing more of those patients in the near future. We're doing a lot of screening at our institution, so anyone who comes in for a procedure is having a test done. Anyone who's starting a new therapy is having COVID testing done. But everyone's walking around with masks, and patients and providers, and you know, the waiting rooms are appropriately distanced. But we paused for a couple of weeks, but we're definitely back up to around 80% of our capacity.
Thank you. Dr. Aggarwal, how are things at Penn?
Yeah, so we are in week 8 of our stay-at-home orders and, you know, practicing social distances as mandated by the governor, both in Philadelphia County, where our hospitals are located, and as well as in the surrounding counties where most faculty and patients live. We adopted virtual visits very early on, about 8 weeks ago, around March 15th, and adopted practices to make sure that both our patients as well as our faculty and staff as well as healthcare workers were safe. We have been actively using both video and audio visits for our patients. And over the course of the 8 weeks, you know, practices have changed from going to, you know, earlier restricting visitors. But now, you know, in addition to restricting visitors, there's universal masking. There is also thermal scanning at all locations that, and all locations or all entries to the hospital are manned by this team of nurses as well as medical assistants who do thermal scanning as well as hand out masks. We were fortunate to get ahead and prepare well. So we did hit our peak mid to late April, but now we are finally starting to see stabilization to maybe an early decline in the number of cases that are hospitalized with COVID-19. And we were always, had enough capacity thanks to the preparations that were put in place by the hospital leadership. In terms of our lung cancer management, we were thankfully able to still perform surgeries as well as biopsies, but we did internally create some guidelines that we were happy were also accepted and published in JCO Oncology Practice in an upcoming issue on management of patients, not just from a biopsy and diagnostic standpoint, but also what to do in terms of radiation and systemic therapy decisions, which I'm sure we'll go into later. But definitely, I think this is a regional issue, and Nashville and Georgia, of course, Atlanta are very different from what Philadelphia and Boston are going through.
And speaking of Boston, Dr. Sands, we haven't heard a lot about how the situation is in Massachusetts, at least out here in the South. So talk to us about how things are at your institution.
Well, we've certainly seen a surge here in Boston, and it absolutely affected workflow in a sense that the hospital, like many, stopped doing elective procedures and really opened up space. We saw an adjustment within Brigham and Women's Hospital, the inpatient area, along with Dana-Farber. Both institutions really adjusting workflow. The ER admitting patients to a COVID team for rule out, and then after we could say that that person does not have COVID, then they could be transferred to a regular oncology team. So set up oncology floors, and we certainly saw a significant influx of patients. We are on the other side of that, still a number of new cases every day in Massachusetts, but those numbers have been improving. Within our clinics, it's been weeks now where we wouldn't allow any visitors to come in. Of course, that's true in the inpatient setting as well. So patients would come in by themselves unless there are some exceptions, although we really try and keep that rare. We are doing a lot by remote, and so many more video consults. And there's been a lot of teaching patients and a lot of grandchildren and children that are teaching their parents and grandparents how to use these video chats and such, which has been in some cases kind of nice, where we've seen family members from around the country that have joined the visit. So I'll see a patient and there may be a couple of their kids that are on the call as well, or on the video as well in these visits. We've been wearing masks and protective gear and doing social distancing, and a lot fewer patients physically coming into clinic with the remote visits. So we really try and keep our waiting room a bit more spaced out or empty, where when patients get there, then they then get roomed immediately to try and help keep everybody safe, really. So certainly seen an adjustment to workflow. I think there are some positives that are coming out of that. But absolutely a significant change in focus within the institution to really try and keep everybody safe. As far as how that's affected our lung cancer care, we've kept our therapeutic clinical trials open. The biospecimen collection studies, if it's just biospecimen collection alone, that has been on hold. But these people with lung cancer, that continues to be a very real, tangible threat to them, and so having treatment options continues to be important. So we have been running those. We've adjusted some of our regimens a little bit at times. Of course, that's from individual to individual. That is addressed, and that will likely change as we see numbers go down with time. So certainly some adjustment to workflow.
Thank you. It looks like there are commonalities between how each of us at our own institutional levels are approaching managing patients during the pandemic. I want to touch on something that Dr. Horn mentioned, which is use of testing to bring patients back into the clinic. Maybe it's worth spending a few minutes talking about how is testing being utilized now for an asymptomatic cancer patient who comes in to resume care or to have their infusion, their radiation, and so forth. So going back, Dr. Aggarwal, how do you use testing now?
Yeah, so, as I was saying, I think our practices have evolved over the past 8 weeks, and we've been learning, as well as due to the availability of a larger number of tests and tests with different turnaround times that are available. We have implemented certain practices for our testing. So all patients get screened with a questionnaire that includes most common symptoms suggestive of the COVID-19 disease, 24 hours and 48 hours prior to the appointment. If they test positive on any of the questionnaires for any question, then an automatic flag is to the providers to determine whether or not this warrants testing. The same questionnaire is also conducted in person, and also a flag is raised if a person has a temperature on the thermal scan when they initially come in, even prior to being vitaled. At this time, we are testing patients that are symptomatic or test positive on the questionnaire. We are not testing asymptomatic patients, but we are testing anyone and everyone who's going to either get surgery, a bronchoscopy, or any kind of diagnostic biopsy, even if it's an IR-guided or an ultrasound-guided biopsy of a liver lesion. This has been mandated just because we've realized that the number of and the percentage prevalence of asymptomatic carriers remains very high.
Dr. Horn, do you test patients who are going to start chemotherapy or targeted therapy? Any form of
so we had a committee sort of come together to decide in this. So we're not testing patients starting on targeted therapy, although recognizing pneumonitis can happen on targeted therapy, and that can be seen in COVID as well. But we are testing any patients who go on myelosuppressive therapy. We have our own tests that we're doing within Vanderbilt. Yesterday, I tested 2 patients who are starting next week, and the test results came back within 3 hours. There is sort of a triage. So for a patient, similar to what's happening with Dr. Aggarwal's institution, so if a patient is getting a procedure, they can go to one of our outpatient clinics that are scattered throughout the county and get a COVID test. But it has to be within 48 hours of a procedure. They can choose to get their COVID test done locally, but that's been more problematic because local labs are not running them as quickly as what we're able to. We are also screening anyone who's going on a clinical trial with 48 hours prior to starting on study, just so that we don't get confused if we see toxicities of what may be causing that. We do recognize that, a patient could develop COVID the day they come for their infusion or treatment, but it's sort of the best that we're able to do and the safest that we're able to do at this point for our patients.
Thank you. So we're all adapting to this, and at least in my experience, when we started off about 8 weeks ago, the initial response on many systems' part was, if it's not emergency care, let's put things on hold. Let's keep patients at home, not in the hospital or healthcare settings where they may be at higher risk for acquiring these infections. And now, 2 months later, we all know that cancer care can't wait for too long, and things are coming back to what we would view as close to normal flow of numbers of patients seen in our clinics. Now, specifically talking about lung cancer, we've seen some data in the past few weeks from various settings and from various nationalities of how COVID patients with lung cancer have done. Specifically in AACR virtual meeting that happened about 2 weeks ago, we saw a lot of data presentations. So let me bring this back to, what do we know about COVID in lung cancer patients? Perhaps I can start with you, Dr. Sands.
Yeah, so we know that people with lung cancer and people with a history of lung cancer have a greater risk of complications if they get the diagnosis. And, there's been some discussion about that. I suspect that has a lot to do with many people having some kind of limitation to their lung capacity. So in the higher risk in people with lung cancer, I'll just say I don't know that that's necessarily the same. Somebody who has severe COPD with lung cancer versus somebody who has an EGFR mutation and otherwise very highly functioning lungs and limited tumor bulk. Those are probably not the same scenarios. But we have to recognize that this patient population, many of whom who even were previously treated, may have an area of their lung radiated or resected, and therefore have some kind of limitation in their lung capacity. And that probably also significantly impacts their risk factors with this. So patients are appropriately very nervous and want to be very careful and make sure that they are not at risk of getting the diagnosis, knowing that their risks are higher. And so we need to take that into account and weigh that out in our risk-benefit ratio for how we proceed with each patient.
Thank you. Dr. Aggarwal, do you think there's a difference in how it affects patients in the United States for the patient populations that we take care of compared to, say, what has been reported from European countries and from China?
Yeah, so, I think going back to your comment about the AACR presentations, I think it was very enlightening to see how cancer patients have been affected by COVID-19. And what really came to light was the dramatic variations and the differences and the variability in how different countries, even though they may be geographically near to each other, have different mortality rates. So, from looking at the earlier publications from China to hearing about the TerraVolt registry by Dr. Garicino, as well as learning about the French experience, we find that there are some differences in how patients with lung cancer have been affected. I'm looking forward to Dr. Horn's presentation next week at the ASCO annual meeting in terms of an update on how thoracic cancers and patients with thoracic cancers are affected. In our experience, I think it's just so hard to distinguish the symptoms from the cancer with the symptoms from COVID-19. And especially, I think, as Dr. Sands pointed out, there are so many comorbidities that are present already that it makes it very hard for us to manage these patients, and they are highly susceptible. I don't think we have a lot of data from the United States at this time, Dr. Ramalingam, to your question. And I really await further presentations at ASCO to really clearly elucidate if we are different from what our European experience has been.
Thank you. So you referenced TerraVolt, and we're fortunate to have Dr. Horn on our panel today. Dr. Horn, you've been at the forefront of trying to collect evidence and data about patients who are affected by COVID, lung cancer specifically, and help the entire community learn from that so we can all make good decisions for our patients. I wanted to talk about how did you go about it? What have we learned so far? And what should folks who are listening in know about COVID and lung cancer from your experience?
Sure. So, TerraVolt started with an email on a weekend where Marina Garicino, who is in Milan, which was really the epicenter in Europe for a while of COVID-19, emailed and mentioned that there were terrible things happening to patients with lung cancer. But there were also tough questions that they were trying to figure out on delaying therapies and how long should they delay. And, we originally thought this epidemic would last a few weeks, and it was clearly going to last months. And so what can we do? And so, we were sitting here in Nashville waiting. And so I emailed back and I said, well, we can help you answer these questions. And so within 3 days, we set up a CRF, case report forms. Within 5 days, we got IRB approval, and very quickly started emailing everybody and saying, let's come together and put this data together. And I think it is a testimony of how collaborative the lung cancer research community is. The first data was presented at AACR a few weeks ago on the first 200 patients. We had 59 centers, 12 countries. I can tell you now we're up to about 500 and something patients. We're at over 22 countries, over 180 centers, and centers can join, and all they need is local IRB approval to enter data. And in Marina's initial data that she presented in the first 200 patients, what we found was that most of the patients were hospitalized, so 2/3 were hospitalized. And in looking we were trying to figure out which treatments put patients at risk, because a lot of people were saying immunotherapy was bad. And what we actually found was that it was age, smoking, and chemotherapy that put patients at risk for morbidity or prolonged hospitalization from COVID-19. But it was just age that was the major risk factor associated with prolonged hospitalization and death. Memorial Sloan Kettering actually had a paper come out last week in Cancer Discovery confirming some of these findings, that the use of immune checkpoint inhibitors was not associated with increased risk of death from COVID-19. At ASCO, what we're hoping to do is update the data, because as Dr. Aggarwal mentioned, the initial outbreak happened in Europe, so a lot of the data that we had was out of France, Italy, and Spain. We've now got multiple US centers that have come on board, and what we're planning on updating the data is looking at how cancer type and stage of therapy may impact outcomes, how number of lines of therapy may impact outcomes. The database is fluid, so when people started talking about body mass index and anticoagulation, we added that in questions to look at how those are associated with outcomes. And what we're also hoping is to provide sort of a risk factor analysis, because when the second wave hits in the fall, we want to be able to say to people, okay, here's the group of really at-risk patients that we need to think about delaying therapy or changing how we're doing therapy. But these patients are at significantly less risk of comorbidities and complications, and so we should continue care as usual. What we also want to find out is the length of delay of subsequent therapy and how that impacts cancer outcomes, because we can't keep delaying therapy forever for our patients.
Thank you. It's a Herculean effort, and we're all better off because of the hard work put in by your team and others across the world. Now, I want to focus more on specific management topics in the next part of this conversation. We'll talk about various clinical scenarios in lung cancer and how management of those patients may or may not change because of the COVID pandemic situation. And we'll start with lung cancer screening. This is early detection of lung cancer is an issue that's close to all our hearts. But Dr. Jacobs, you've been spending a lot of time thinking about it and working on it. So I want to come to you to talk about how do you approach the issue of lung cancer screening in the COVID pandemic?
Yeah, it's wonderful that you raised that topic, because as this pandemic is happening, we've really been kind of on the up curve of seeing programs develop. It's more and more over the last few years in particular, people are starting to really recognize the value of lung screening. In the U.S., the American Lung Association estimates that about 48,000 lung cancer deaths would be prevented each year if lung screening were happening by current guidelines for everybody that qualifies. And to put that into context, that's more lives saved each year by lung screening than we would save by curing breast cancer each year. And of course, we want to cure breast cancer. That's not to pit against in any kind of a way, but just to frame that in a way that the number is better understood. So we've seen programs really building up, but now all of a sudden this pandemic hits, and there's suddenly more risk in coming in, and we're figuring out how to do things more remotely, but obviously we cannot do a remote CT scan. So what we've seen is many hospitals have put their lung screening on hold. People who are coming in for just their yearly screening scan or starting as a baseline, those are on hold. If there's a nodule that's being followed, so in screening, sometimes we'll see a nodule that is indeterminate, still on the smaller side, but could represent a cancer. These patients will come back 3 months, 6 months, and have a follow-up scan to monitor for any growth of that nodule. And those are a bit more important to do, so those are being prioritized as opposed to the yearly scans. That being said, there are institutions are now looking at how to move this forward, how to continue to do screening in a way that keeps patients and staff safe, and finding innovative ways to clean rooms to make sure that the scanner is safe for patients and such. I suspect that this will all become easier with time, as depending on how much testing can really be ramped up, and the more we can test people, the more we can feel a little more comfortable, although recognizing that not every negative test is that there are some false negatives out there as well. So I think this is the new work, is how to continue screening to make sure that we are catching these early stage lung cancers when it's really most curable, and that's gonna take some innovation and workflow. As I mentioned, it has been on hold, but as has been said about lung cancer, this is not something that can perpetually remain on hold. So I think for a few months, that still is okay, and then we need to make sure that the people who haven't come in are now getting back in, because we've also seen that when there's a long delay in that yearly scan, if that were to go out to 2 years, the stage at which people then get diagnosed, we've also seen a shift in that out of the Nelson publication that was presented, where there was a more later stage disease when there had been a 2.5-year gap, as opposed to the 1 year between scans. So it continues to be really important to make sure we're getting these people in.
Thank you. You make some great points there. We're just beginning to make some major headway in reducing lung cancer mortality in the country. And it is at a critical juncture as this that we don't want to lose sight of early detection, which is a key issue to continue to push the envelope on reducing mortalities. While slowing during the pandemic for a few months may be okay, we just can't afford to take our eyes off early detection of lung cancer. Now, at that same end of the spectrum, talking about early stage lung cancers, I know it was mentioned earlier that surgeries are being delayed. So let me come to you, Dr. Aggarwal. Talk about what are you doing for patients with resectable lung cancer that are diagnosed now? Are they able to go for surgeries if they have to wait? Do you do something in the intervening period? What guidance can you give us on that topic?
Yeah, absolutely. I think this is a great topic. We were fortunate that the ACS, the American College of Surgeons, put out guidance early on during this pandemic as a guidance to really help surgeons allocate resources towards best management of patients with lung cancers. And they had different phases of recommendations depending on the availability of ORs, as well as availability of ventilators and just the local resources in terms of personnel. And, you know, certainly centers that have been really hard hit, like New York, did defer some of these surgeries for a time period, although most of them are now resuming surgeries. In Philadelphia, we did also delay some surgeries, but these were really decisions that were made on a case-by-case basis. You know, tumor sizes less than 2 centimeters or well-differentiated carcinoids, patients with negative nodal involvement, or patients that we thought we could defer for a few weeks were deferred. However, I have to say, we were able to safely take patients to surgery for almost all other indications, even during the past 8 weeks, and that has continued to be the case to this day. But definitely, I think different regions have handled this differently, and we've been fortunate not to really delay too many definitive resections.
Thank you. So, staying with the same topic about early stage lung cancer, Dr. Horn, I'm going to bring you in on discussing adjuvant chemotherapy in this setting. And I'll give you an example. I saw 2 patients last week in my clinic. These were patients who had resected lung cancer, but their surgery was done just before the COVID pandemic started. So they would have ideally come to us within 3 or 4 weeks after surgery in previous times, but because of this, they came to see me about 9-10 weeks after the surgery. And both of them had involvement of N1 lymph nodes, one had a 9-centimeter primary tumor. And these are patients who we would definitely have wanted to give cisplatin-based adjuvant chemo. Now here there are two questions. One is cisplatin-based chemo, which we just heard from you, is associated with higher risk of developing complications from COVID, appropriate in the setting? And B, a patient comes 8-9 weeks after surgery, is this still okay to go ahead and give adjuvant chemotherapy? I would love to hear your thoughts on that.
Yeah, so the chemotherapy, I think, is a little bit easier to answer. You know, we don't know if cisplatin is any better or worse than, say, carboplatin. I would argue that carboplatin is probably even a little bit more myelosuppressive. And so I think that the cisplatin would still be my first choice and appropriate to administer to the patient. The 8 or 9 weeks, you know, most of the adjuvant studies were within 12 weeks. So I would still offer those patients adjuvant chemotherapy. One of the things that we've been doing at our institution, how we're managing this, is the patients are often seeing the surgeons for a telehealth visit post-op. And so we're tagging on to the telehealth visit and discussing adjuvant chemotherapy, or we're having a separate telehealth visit and discussing adjuvant chemotherapy with the patients at that visit, which is normally a 3 to 4 week visit. And then we're helping them decide, you know, we have a lot of patients who do not live close to Nashville, and so they're coming here for their care. I am convincing more patients, you know, chemo is chemo. We don't have studies right now for this. If you would like to get your therapy close to home, let me set you up with a local oncologist. I've had one patient who didn't want to do that because at our institution, similar to what everyone else is doing, we're taking temperatures of everybody who comes in the door. Our infusion rooms, each room is a separate room for a patient, and so they feel like there's more social distancing going on within our institution than what they were having locally. But I would still offer these patients adjuvant therapy. I think for those patients who were sort of borderline and didn't do so well with chemotherapy, with surgery, had multiple complications, maybe they're slightly older, and you were worried that they would even get through chemotherapy, those are the patients that I may say, maybe we should just watch you.
Mm-hmm. Thank you. Dr. Sands, you are the principal investigator for a large national trial sponsored by the NCI that's going to open soon, specifically looking at integrating chemo and immunotherapy in the adjuvant therapy setting. I want to ask you about how you approach the issue of growth factors in these patients. Typically with adjuvant chemo, most of us would not give prophylactic growth factors. Does the pandemic change your approach?
Well, I appreciate you highlighting that trial. It is opening soon, and it's a 3-arm adjuvant chemo versus a sequential adjuvant chemo followed by checkpoint inhibitor versus a concurrent chemo plus a checkpoint inhibitor. Amazing time, but it is opening soon as part of the Alchemist studies. But to your question, as far as these, you know, I will say there are some scenarios where I am using growth factor where maybe I hadn't before, which is, you know, where it's still approved, and scenarios where maybe others are using at times, but where I haven't typically. This is really more in like small cell lung cancer with platinum etoposide, not in people getting radiation, but just, you know, extensive stage. I have done that, but, you know, it's a case-by-case basis. I think it's hard to make a sweeping generalization. You know, I agree with Dr. Horn in the way that she outlined when she may use treatment versus the complicated patients who have had a complicated course already with surgery. and where that being a situation where maybe you wouldn't. If I have a patient that still meets that line where I want to give them treatment, but I am a little concerned about the possibility of neutropenic fever, that being one of the complications that lands people potentially in the ER or hospital, which obviously we're trying to avoid, particularly during surges. But that I still think that they can handle the treatment and the benefit is there, then I may consider doing that in kind of that in between. I will stress, these are people that we're trying to cure in the adjuvant setting, and of course recognizing that the chemotherapy is not the be all, that it bumps people's chances somewhat, but not dramatically. So we do want to get them that treatment. We do want to get people to cure. Curing their lung cancer obviously significantly impacts their lives going forward. But that's part of the balance. And so some people use it, particularly around concern of infection and just minimizing the time of neutropenia.
Thank you. That was very helpful when it comes to managing early stage lung cancer, how we use adjuvant therapy, what's the current situation with the ability to get surgery and specific strategies to minimize the risk for our patients. Now let's think about patients with stage 3 lung cancer who we give combined modality treatment approaches. Knowing that we don't have a radiation oncologist in the panel, I'm just going to come to you, Dr. Aggarwal, to talk about how is chemo-RT for stage 3 patients being given, any specific precautions you take for this group of patients, and also any specific regimens you go to weekly versus every 3 weeks to reduce patient exposure to the healthcare system.
Yeah, absolutely, Dr. Ramalingam. I think this is such a heterogeneous disease that we started thinking about this early on during the beginning of this pandemic, really to think about how to best manage patients that have clearly unresectable disease and treat them in a manner that's safe but yet effective. So all of these patients were discussed at our multidisciplinary tumor boards that were conducted virtually. And for each patient, we would discuss whether or not we could safely proceed with a concurrent approach, which is our current favored standard of care regimen. And I'm happy to report that we were able to choose concurrent chemoradiation therapy for most of these patients. We also had discussions about perhaps using hypofractionated regimens. There have been smaller trials as well as smaller reports of using abbreviated radiation schemes, 20-day schedules for patients with locally advanced unresectable non-small cell lung cancer. However, they have not been really favored into practice because of the lack of large numbers and randomized data. However, our radiation oncologists have considered using these, again, in an attempt to minimize the amount of time that the patients spend in aggregate, as well as limit the number of patients at the center on a given day. In terms of chemotherapy regimens, we also discussed using Q3 weekly chemotherapy regimens instead of the weekly carboplatin and paclitaxel-based backbone. There's data from Proclaim that supports using a platinum and pemetrexed-based approach, at least for the non-squamous non-small cell lung cancers. And we have certainly used that for some of the patients, again, in an attempt to minimize their interaction with another set of nurses, another set of providers. So while we still conduct weekly toxicity evaluations for these patients via telehealth, at least they're not coming in contact with 5 other healthcare providers. And lastly, I will say that there is data to begin consolidation immunotherapy as early as possible, which we've always wanted to do and always tried to do. I think in these times, we have given ourselves a little bit of leeway to make it okay to start within 4 to 6 weeks of completion of chemoradiation therapy, just again in an attempt to make sure that patients are they're healthy and they've recovered from their initial chemotherapy and radiation toxicities before we begin durvalumab. And we've been using durvalumab on a Q2-week dosing at this point in time. But really hoping that the Q4-week dosing for this indication will come soon.
Thank you. Dr. Horn, anything differently you want to add from how your institution approaches stage 3 disease?
No, we're doing a very similar approach. We have also been talking about durvalumab with the Q4-week dosing, and we're probably going to be starting that within the month. It is approved in small cell, and so I think that we're going to be going to that very quickly.
We have done that for the past few months, and we've not had any problems getting reimbursed. We've had some questions asked about it from some particular payers, but largely it's not been a problem for us. Now, talking about chemo-RT, slightly going off course, the hypofractionated schedules that Dr. Aggarwal mentioned brings up the question of BID radiation for small cell lung cancer. Dr. Sands, do you find that more radiation oncologists are now offering BID radiation to shorten the time for patients in the system?
Well, yeah, that has actually been a preference, I think, of our radiation oncology group in general, if patients are willing to do that. So it still is very much up to the patients. I have noted recently it does seem like a few more have been doing that schedule as opposed to daily. But I don't think there's any, if patients for whatever reason end up wanting to do daily, we're still doing that if they want.
Okay, great.
Our institution as well was doing BID on the patients who were able to tolerate it.
Thank you. Now let's shift gears, and for the last part of this, spend time talking about advanced stage non-small cell lung cancer. And I thought it would be helpful to think about some cases that we encounter in our clinics. First, Dr. Horn, let me get back to you. A 78-year-old patient diagnosed with stage 4 lung cancer who has an EGFR exon 19 deletion mutation. Is there any reason to think about changing the treatment approach for this patient away from using an EGFR tyrosine kinase inhibitor? Are there any different ways of approaching how you would manage this patient than what we would otherwise do in a pre-pandemic era?
So the only thing that we're doing a little bit different for these patients, so we would still start them on osimertinib, but we used to bring the patients back about 2 weeks after starting their TKI, check their counts, their platelets, their neutrophils, their LFTs, and we also would do an EKG because we had seen some patients with QT prolongation, one that we had actually had to discontinue therapy. What we're doing now is we're doing a telehealth visit 2 weeks later. We're having them do local labs. We're either in their hometown, or if they live in Nashville, several Walgreens are drawing labs, are affiliated with Vanderbilt, and they can draw their labs there. Or we're sending them to one of our satellite clinics so that they can get their EKG done there. We're not seeing them in person. These were I found that the patients with metastatic disease who are on TKIs have been the easiest patients to manage for 2 reasons. One, we only saw them every 3 months anyway, unless there was an issue. Also, with the data that came out of TerraVault, is patients on targeted therapy were at significant decreased risk of developing severe complications from COVID. Now there is definite overlap. They have less comorbidities, they're younger, they don't smoke. But for those patients, it's been a little bit easier because we don't see them as frequently.
Dr. Aggarwal, would you say this also applies to other targeted agents? We now have 7 targets in non-small cell lung cancer that have approved therapeutic agents. Is there any other targeted agent where you see we should use different set of guidelines or a different approach from what Dr. Horn just mentioned?
Yeah, I think we are practicing very similarly. I think we don't we don't have data on if one TKI is different from the other in the setting of COVID-19. So I think we're using our clinical judgment and really basing on patient symptoms, as well as starting therapy, especially with targeted agents, if a patient is a candidate. So I personally don't think that there are significant differences, but again, this is a data-free zone.
Great. Now let's talk about immunotherapy. And Dr. Sands, how is immunotherapy being used in your clinic in the pandemic? Are you making any changes to how you use immunotherapy from before to now?
Generally, I have not. Immunotherapy, I continued to prescribe. I guess the one thing was really as we were anticipating a significant peak, at that time frame, I had maybe one cycle for people who had been on it for a year and a half, doing well without any side effects, good disease control. And these individuals, I would end up skipping one cycle or delaying one cycle. I'm not doing that as far as consistently delaying people's cycles. I think it's important to keep people on the regimens that we know. One change has been with pembrolizumab now being approved at 6 weeks. I have started changing patients who were on pembrolizumab already, is changing them to the 6-week dosing to minimize their office visits. But otherwise, the only change has really been just one cycle, whether I would delay or just skip one cycle. That wasn't as much for people who have just started on therapy. I mean, I think that's a different scenario than someone who's been on it for a really extended time.
So if you had a patient...
I will just...
Sorry, go ahead.
So I will just add to Dr. Sands' point here that patients who've been on immunotherapy for a very long time, in my practice, we're talking greater than a year, and have had really excellent clinical and radiographic responses. I have spoken to them about, skipping a dose or two here and there, again, recognizing that these antibodies otherwise have long half-lives, and, decreasing their exposure to a healthcare facility is probably, more beneficial to them than receiving another dose of immunotherapy. And now with the every 6-week dosing for these kinds of patients, I think we'll be adopting more of those approaches.
Fair enough. Now, we use immunotherapy as single agent for patients with high PD-L1 expression. For patients who have low PD-L1 expression or negative PD-L1 expression, our approach in recent times has been chemo with an immune checkpoint inhibitor. What I've heard some investigators or some clinicians say is that in a patient with low PD-L1 expression, at least during the pandemic, they're still giving just single agent immunotherapy, particularly pembrolizumab, and avoiding the combination with chemo in order to minimize problems for patients. Is that an approach you've seen happen in and around your practice, Dr. Horn?
I haven't. I think that that's interesting. I don't think that that's an approach that I personally would take. I think that the combo data is quite compelling. And so I haven't seen patients coming in just getting a single, getting pembrolizumab alone, and I personally have not done that for patients. One thing that I have done more of is I generally stop patients at 2 years, because I personally don't think that there is good reason to just continue a checkpoint inhibitor indefinitely. We have so many patients now who are alive and well 7 or 8 years after discontinuing therapy from their original phase 1 trials. And so for those patients who were continuing beyond 2 years, I'm starting to tell them, at the risk of COVID, I think that the risk of continuing therapy is just not there. And so several patients have actually agreed to come off of therapy and just be monitored, which is a CT scan every 3 or 6 months, depending on how far out they are from discontinuing therapy.
Yeah, I just want to piggyback on that, because that's absolutely been my practice and many within Dana-Farber around at 2 years stopping. And so even leading up previously, I was generally stopping checkpoint inhibitor at 2 years and then monitoring. And to Dr. Horn's point, there are a lot of people with ongoing disease control off of therapy. And I know this tends to be, this is a topic of debate and discussion currently, but that was my practice before, and I've continued that.
Now, when we give chemotherapy and immunotherapy for patients, we give them maintenance therapy. In non-squamous patients, at least, they end up getting methotrexate and pembrolizumab. Has the maintenance piece of this treatment changed during the COVID pandemic? Dr. Aggarwal.
Yes, so it's been my practice to continue both the pemetrexed as well as the pembrolizumab in the maintenance phase pre-COVID for my non-squamous patients that started with the triplet. I have not changed my practice. However, what I have changed is for my patients that have had, again, long-term disease control and otherwise are doing well, I have on a case-by-case basis talked to my patients about changing the frequency to perhaps 4 weeks. I certainly have not gone beyond 4 weeks, but certainly considered that for some of my patients. And for my monotherapy patients, I think I would feel very comfortable going to the Q6-week dosing for pembrolizumab. But I have continued both drugs for my maintenance.
How about the use of second-line chemotherapy, Dr. Horn, particularly when you talk about docetaxel, ramucirumab? Talk about, is there a preference in your practice to do combination, single agent, any dose reductions at the game outset?
So we were always doing dose reductions. So for docetaxel, I've actually only used 75 milligrams per meter squared when I put a patient on a trial. I generally have always used the Japanese dose or Asian dose of 60 milligrams per meter squared with or without ramucirumab. You know, the biggest change that happened in second line is we had so many trials open, and suddenly all clinical trials came to a halt, either through our own institution or from sponsors. They're starting to reopen again, so we can offer patients something beyond standard chemotherapy. But I have given a few patients lower doses of docetaxel with ramucirumab in the past couple of months because I didn't have a clinical trial to offer them.
Any other thoughts on this from our other panel members?
Well, I'll say second line has become, you know, it's different now in the checkpoint inhibitor era. We got used to checkpoint inhibitor being a second line therapy, and I now see kind of a shift as we got used to some of the various newer therapies. Now to go to docetaxel, the enthusiasm about that in general has really decreased. We really try and put people on clinical trials as much as possible, and as Dr. Horn was saying, there's a lot happening in this space, and so usually we can find trials for these patients. Enrollment for us did decrease a little bit if patients required an investigational biopsy prior to enrollment. We kind of have a few weeks now where we weren't able to get biopsies only for the purpose of enrollment to trials. We could still do clinical biopsies, so that has limited enrollment to some trials. But otherwise, I have not really been a big adopter of ramucirumab, and so generally speaking, I really would end up doing just docetaxel even before this, so that would still be my practice.
I'll say one thing that also our institution has been very proactive about, but probably even more so now, is the patients, not necessarily second line, but third line, or patients who are getting a little more frail. I've definitely had more discussions about palliative care and goals of care, because at our institution, if you get admitted to the hospital, you're on your own. You know, we're not allowing family and visitors in, and it's lonely for the patients. It's stressful for the house staff and whoever's taking care of those patients. And so I've had some really frank discussions with patients. You know, we can do this, but you are at high risk for being admitted, and you may end up dying by yourself in the hospital, or we can set up hospice and you can be at home and be with your family. And so I've definitely had more of those frank discussions with our patients because of these concerns.
Great point. Thanks for reminding us that these decisions that are made in the time of COVID pandemic affect patients in many ways. Some we see directly, some we may not appreciate to the extent that not having a visitor affects how a patient's recovery and overall outlook towards the cancer journey may be influenced. We're almost running up to time. I just want to have a parting thought or two from our panel before we close. So I'll start with you, Dr. Sands. Any specific advice, recommendations you have for oncologists taking care of patients with lung cancer that we've not discussed so far?
Well, I think we can kind of sum up the discussion in some ways by saying, you know, we've always, with every patient, we look at risk-benefit balance. And so this is that same kind of practice that we've always done. I think the risks obviously have shifted and will continue to shift depending on what is going on in that region and in that institution at any given time. So the practice that we're doing now, you know, it still kind of fits into the analysis we've always done. Treating lung cancer continues to be very important, and detecting early stage lung cancer continues to be very important. And clinical trials, as part of that, ends up being important therapy for patients that are dealing with the greatest threat to their lives being when they have active lung cancer. So it's important that we continue to find ways to forge forward. It is a new era, and it's probably not going to change anytime extremely soon. So we need to develop new strategies for continuing to keep everybody safe and treat them.
Thank you. And Dr. Aggarwal, briefly, do you have any recommendations for patients and caregivers with lung cancer?
Yeah, I think this has been a very exciting hour, and a lot of good information has been shared. I would just like to touch upon clinical trials. I think this is on everyone's minds, as well as patients and caregivers, and would just like to say that even during COVID, we've tried our best to keep our key essential clinical trials open and provide these trials to our patients in a safe and effective manner. And as we emerge out of this pandemic, more and more clinical trials will be available. So patients should not lose hope about access to new investigational promising agents.
Thank you so much. I think we're running out of time, so I'm going to close by, first of all, thanking all of you, our audience, for joining us today. Thanks to all my colleagues for participating. Dr. Horn, we look forward to your presentation at ASCO from the TerraVault Registry, which will hopefully provide us with additional insights beyond what we have talked about today. We hope that this discussion has been helpful to you, our viewers and audience, to apply to your practice. We also hope that you will join us again in the month of June for new COVID-19 episodes on hematological malignancies, GU cancers, gynecological malignancies, and even a repeat program on lung cancer. And registration to these events is open at bioascend.com/COVID-19. Thank you very much and have a great day.